afternoon, and welcome to the Gritstone Bio KOL webinar on oncology product candidates GRANITE and SLATE. At this time, all attendees are in a listen-only mode. A question and answer session will follow the formal presentations. If you'd like to submit a question, you may do so by using the Q&A text box at the bottom of the webcast player or by emailing your questions to questions@lifesciadvisors.com. As a reminder, this call is being recorded and a replay will be made available on the Gritstone Bio website following the conclusion of the event. I'd now like to turn the call over to your host, Dr. Andrew Allen, co-founder, president, and chief executive officer of Gritstone Bio. Please go ahead, Andrew.
Thank you, Tara. Well, good afternoon, good morning, everybody, depending upon where you're located. Pleasure, excuse me, a pleasure to be with you today. As many of you know, my name's Andrew Allen. I'm the CEO, one of the founders of Gritstone Bio, based today in the California Bay Area. It's my pleasure to introduce two speakers who are joining us today, both live in Paris, so they're actually in the same room. First of all, we have Dr. Daniel Catenacci, who gave the mini oral presentation on the GRANITE data earlier this morning. Dan is the assistant professor of medicine at the University of Chicago, and he is joined by Professor Thierry André, who is professor of medical oncology at the Saint-Antoine Hospital in Paris, and they'll both be speaking to you today. I'll be making some forward-looking statements during the course of this webcast. Our agenda today is to go through 5 elements. First of all, I'm going to briefly give an overview of our neoantigen immunotherapy, and I'll cover this swiftly. Many of you have heard this before, and some of the relevant and technical data are published in the scientific literature. Then I'm going to cover this SLATE off-the-shelf neoantigen cancer vaccine product, and I'll be sharing with you some data from our version 1 of this product, and then describing the optimized version 2 that we've built using translational medicine data from the first study from the human data. And I'll explain what the version 2 looks like and where we're taking it. Then I'll hand over to Dan, and he will describe with more time and with some more depth the GRANITE data, which he presented in part earlier today at the mini oral. Then we'll hand over to Thierry, who will cover the unmet need in colorectal cancer. He'll describe current treatment options and describe the persistent unmet need that obviously we are seeking to address. And I will then close by describing the 2 randomized phase 2 studies that we'll be running at the beginning of next year in the setting of microsatellite stable colorectal cancer. But unlike the data you'll see today, which is in end-stage patients, the phase 2 studies will be further upstream in the patient's course. So let me begin with an overview of our neoantigen immunotherapy programs. As many of you know, the benefit of immunotherapy appears to be primarily limited to subjects who have an existing neoantigen-specific CD8 T-cell response at baseline. These tumors typically have high tumor mutational burden. There are usually infiltrating CD8 T cells in the tumor at baseline, and PD-L1 expression is often upregulated. And these patients can do extremely well on checkpoint inhibition with very substantial long-term benefit, which obviously has really transformed the field of solid tumor immunotherapy over the last several years. But unfortunately, the very common solid tumors that kill most people often are cold tumors that have low tumor mutational burden, low PD-L1 expression, and often no infiltrating CD8 T cells. And if those patients are treated with a checkpoint inhibitor, unfortunately, little useful happens apart from sometimes the development of autoimmunity. The therapeutic hypothesis that we're pursuing is that we can perhaps bring those patients into the light, as it were, by providing them with neoantigen-specific CD8 T cells. And we do so by taking a tumor biopsy, predicting neoantigens, putting those into a potent vaccine. We use a prime boost, a so-called heterologous prime boost, with a chimpanzee adenoviral prime and a self-amplifying RNA boost. They contain the same set of neoantigens, and for GRANITE, those are 20 neoantigens selected for that patient. So the product is made for that patient. Whereas for SLATE, it's a fixed set of, quote, off-the-shelf neoantigens, and we look for patients who have the right tumor mutations for therapy with SLATE. And then hopefully these will induce CD8 T cells, which will then traffic to the tumors and remain active by virtue of concomitant administration of systemic checkpoint inhibitors. So that's the therapeutic hypothesis that we're pursuing. And today we're going to show you data addressing that hypothesis. Now, first of all, neoantigen identification has been historically challenging, and we've spent several years now building a prediction model that starts just with formalin-fixed paraffin-embedded tissue. We wanted to have a system that did not require complex live cells or fresh tumor biopsies, but something that would be useful in the community where the common currency for a typical solid tumor patient is a formalin-fixed paraffin-embedded core needle biopsy. That means we can really only use sequencing data as the input. And so we trained a model using human tumor samples where we did identify surface presented peptides, and we correlated those with the genomic features of those same tumor samples based on DNA and RNA sequencing. And we built a machine learning model that we called EDGE that can now take us just from sequence data alone to high probability prediction of relevant neoantigens with over 70% positive predicted value. This work was published in Nature Biotech at the end of 2018, and we have issued US patents covering this work. That's half of the puzzle. Now you've identified the neoantigens, you need to put them into a vaccine that will elicit strong CD8 responses in humans, which is challenging again. Most vaccines do not elicit CD8s. And so we've developed this so-called heterologous prime boost system. We prime with a chimpanzee adenoviral vector that drives a very strong CD8 response, as well as CD4s and antibodies where that's appropriate. And then we boost with a self-amplifying RNA vector. Again, we don't have time to go into this today, but this has some meaningful differences from mRNA vectors, which of course we're all familiar with given their dramatic success to generate neutralizing antibodies against SARS-CoV-2. Self-amplifying RNA potentially drives stronger immunogenicity with CD8 responses at a potential lower dose than mRNA, and that's why we selected to use SAM. It's given in a lipid nanoparticle. And we then take these two platforms and put them into patients. Again, we have the two overall programs, GRANITE, which is the individualized program, and SLATE, the off-the-shelf. And we're going to show you data today demonstrating that these are well tolerated. The only vaccine-related adverse events are those associated with strong immune responses. And we have early signs of clinical efficacy, including objective molecular responses. And further, we've learned a fair amount about how to optimally dose these products as we move forward into our randomized studies. So let me describe SLATE. SLATE is our off-the-shelf product. We've demonstrated, and you'll see the data again today, that this is well tolerated with no dose-limiting toxicities in the phase 1 program. We'll show evidence that in non-small cell lung cancer patients, all of whom had progressed on prior immunotherapy, sometimes with chemotherapy as well, that we're seeing evidence of activity here with the SLATE product. That is probably greatest in the 6 patients that we've treated who have the KRAS G12C mutation presented by HLA-A0201. And in the subset of these patients who had measurable ctDNA, circulating tumor DNA, we observed molecular responses in 2/3, which correlated with clinical benefit. And we've seen one RECIST response, an unconfirmed response in one patient. And I'll show you these pictures and images today. And as I mentioned earlier, we're bringing a version 2 forward into the clinic. And that first patient has just been dosed with version 2 of SLATE, as we announced this morning. So here's the basic idea. You have several different KRAS mutations within the vaccine. But it's not enough just to have the mutation. You do need to have the relevant HLA class 1 allele to present that mutation. So patients are screened for the presence of both the appropriate pair, KRAS mutation plus HLA allele. And this adds up to about 10 to 15% of lung adenocarcinoma and around the same fraction of colorectal carcinoma patients being eligible for treatment with this first product. We've treated now 26 patients with version 1, and all of the data I'm showing you today are from version 1 of SLATE. You can see here that half of those patients were non-small cell lung cancer patients, all of whom had received prior anti-PD-1 therapy, and indeed a median of 2 priors, typically, of course, chemotherapy as well. And we treated some patients with microsatellite stable colorectal cancer and pancreatic cancer and a couple of other rarer types. And in terms of the safety on the side, on the right, you can see that the common treatment-related adverse events are fever, as is often seen with potent vaccines, fatigue, and some injection site reactions, all of which are transient and self-limiting. And the grade 3/4 toxicity was typically seen with checkpoint inhibitors. This is the traditional RECIST assessment, and you can see the partial response that I described in a non-small cell lung cancer patient. This was not confirmed, and I'll show you those data shortly. But of course, we are innovating here and doing something that has never been done before in solid tumor patients, to treat them with a potent neoantigen vaccine. And we do not know how efficacy will be manifest. And tumor shrinkage, of course, is desirable, but is not necessary for clinical benefit. And I think there's a little bit of a syllogism floating around at the moment that says RECIST responses are good, neoantigen vaccines don't have lots of RECIST responses, therefore they are no good. And of course, that is irrational. That's a false conclusion. And I think we need to open our minds to the fact that with T-cell infiltration into lesions, shrinkage may not be what we see, different from what we've seen with prior therapies. And that's why the molecular responses are particularly important here. And of course, we've seen evidence of this phenomenon playing out with other products, and most notably Immunocore, with their bispecific product, have demonstrated in a subset of melanoma that clinical benefit was profound, with an overall survival hazard ratio of around 0.5, and yet RECIST responses were single digit and barely higher than in the control arm, suggesting indeed that there is now a wide separation between true clinical benefit and what we may be seeing using traditional RECIST response developed for cytotoxic therapies. So here are the molecular response data. And here we're measuring the amount of mutant KRAS DNA in plasma at baseline. And these assays are sensitive, but some patients have low concentrations, which are not necessarily measurable. So not all patients will be informative when you're looking for a single mutant DNA form. You have a much higher sensitivity when you're looking for multiple forms, which is why generally most of our GRANITE patients are positive, because there we're looking for at least 20 different mutations in the blood. But here with SLATE, we're just looking for KRAS, and you can see on the left here are all of the non-small cell lung patients where we screened for ctDNA, and 5 of them had detectable baseline ctDNA. And over on the right, you can see that 3 of those 5 had molecular responses that correlated with treatment for over 12 weeks. Now, focusing on the KRAS G12C subset, here we had 6 subjects, and we're looking now at their time on study, time on treatment, compared to their immediate prior treatment. And this is the famous PFS2, PFS1 ratio, the general idea being that as your cancer progresses, you will spend less time on subsequent, second and third lines of therapy compared to first. So in other words, a PFS2:1 ratio over 1 is soft suggestion of benefit. And if you look on the right, you can see that clearly we have that suggestion of benefit in several subjects. This is, in fact, the last patient we treated with SLATE version 1, a 53-year-old man with metastatic non-small cell, who presented in the summer of 2020 and was treated with standard pembrolizumab plus chemotherapy, but developed rapidly progressive disease after just 3 months. He came into our study and began SLATE immunotherapy in January of this year. And you can see that he had around 17% tumor shrinkage at the first scan, that then turned into a 47% shrinkage at 4 months. And this was associated with what is now a fairly common ctDNA pattern for us, where you have an initial spike in ctDNA, which we presume is tumor lysis, followed by clear molecular response. Radiologically, you can see that this patient had several clearly measurable target lesions, and obviously these all shrank as you'd expect given the data I just showed you. Unfortunately, at around 5 months, he developed relapse in a vertebral body with evidence of acquired resistance and breakthrough in a vertebral body, which led to disease progression. This was the second patient we treated with SLATE version 1, an 84-year-old lady who had previously progressed on pembrolizumab therapy. She didn't tolerate chemo well, came into our study and was on for around 6 months with around 20% tumor shrinkage and a molecular response, as you saw on the previous slide. She did not tolerate the fatigue associated with checkpoint inhibitors well, however, and came off of all therapy at around 6 months for improved quality of life. And then finally, this interesting case, a 55-year-old man with metastatic non-small cell KRAS G12C again, progressed on pembro chemo after around 8 months of therapy, and has been on study now for 2 years. Actually, he's just come off all treatment. He's never been ctDNA positive, so we don't have that readout for him. But you can see that he's had this very persistent, roughly 20% tumor shrinkage. He's asymptomatic, in good health, and now off of all treatment. Now, the version 1 product that we had included some p53 mutations as well as KRAS, and we learned that p53 was immunodominant and probably crushing the magnitude of the KRAS-specific responses. And you can see this here in an HLA-A11 transgenic mouse, where G12V and G12D can be presented. But with the version 1 cassette, looking at those dark-colored dots, there's really very little measurable T-cell response. With version 2, we've removed p53 from the cassette. It's pure KRAS. We have multiple copies of the KRAS mutants, and you can see now we get strong T-cell induction. And this is the product that's gone back into patients, and we're dosing 3 cohorts: first-line colorectal maintenance, third-line colorectal, and another group of patients who have non-small cell lung cancer and have progressed on prior immunotherapy. So we're waiting to get those data, obviously, and we're anticipating having some data roughly mid-2022. Let's turn to GRANITE. What Dan will show you is that, again, we have good safety and tolerability with the GRANITE personalized neoantigen vaccine. He'll describe the efficacy with the induction of strong CD8 T-cell response that's associated with ctDNA molecular responses in 4 out of our 9 colorectal patients where we have measurable ctDNA, and that correlates with clinical benefit. You'll also see that the 12-month confirmed progression-free survival rate is around 30%, which compares very favorably with historic controls. And then we'll be moving this forward into randomized studies, which I'll describe at the end of the presentation. And with that, let me hand over to Dan. Thank you very much, Dan. Over to you.
Thank you very much. It's a pleasure to be chatting with you today and building on the talk that I gave earlier at the mini oral. So we conducted, as you heard in this GRANITE study, a phase 1 dose escalation study with adaptive design, holding the ChAd vector dose constant and increasing doses of the SAM boost, along with subcutaneous ipilimumab and IV nivolumab given monthly doses for 6 months and then every 3 months thereafter. You can see in the phase 2 expansion cohorts which remain ongoing, microsatellite stable colorectal cancer, gastroesophageal adenocarcinoma, and non-small cell lung cancer expansion cohorts. And the primary objective of the study, safety and tolerability, overall response rate by classic RECIST, and recommended phase 2 dose. Because we're selecting for neoantigens, one question is, are we enriching for higher tumor mutation burden or other biomarkers that would suggest that we'll have a response just to immune checkpoint inhibitors alone? And what you see here on the left, compared to the TCGA cohorts, historical cohorts, is that that's not the case. So the TMB remains quite low in the patients enrolled in our studies. You can see there by color coding of the specific tumor types, and the PD-L1 also lower than the reference TCGA cohorts. And on the right, similarly, interferon gamma signatures are not enriched or upregulated in any way in the GRANITE patients compared to the TCGA. So with that, we see the patient demographics that were enrolled on the study on the left, a typical median age range, and you can see the numbers per tumor type. A large group were enrolled were MSS colorectal cancer. And on the right, similar to the SLATE, you can see that treatment-related adverse events, about 5%, were most commonly were fever, injection site reaction that were self-limiting, and the remainder were typical of what you'd see with immune checkpoint inhibitors alone. Very importantly, I think we see here that the vaccine strategy consistently induced neoantigen-specific T cells, and that the baseline samples demonstrating a lack of a T cells in these patients really reflective of their general poor immunogenicity. So here are the RECIST data, and so you can see here that of the 22 evaluable patients, that we had 1 complete response, and a number of patients with stable disease with a disease control rate of 27%. And so we'll be focusing now on the MSS colorectal cancer patients because classically, immunotherapies are not known to be effective in this disease. So we're going to look at these patients here with stable disease and also patients who had progressive disease but were treated beyond progression. And so again, compared to other tumor types, colorectal cancer that's MSS specifically, which again is the majority of the disease, more than 95% of stage 4 disease is MSS. You can see here with PD-1 therapy, PD-1 and CTLA combination blockade really shows no benefit from these therapies, PFS on the left and OS on the right. So that's the baseline from what we're coming from. And also in this cohort, there were some MSI high tumors here in at least 2 of the patients, but not all patients had a known MSI high status and known microsatellite instability status. So we know that MSI high patients have a clearly different potential for response from these immune checkpoint inhibitors alone. And so in the patients treated in the GRANITE study with MSS colorectal cancer, you can see here on the swimmer plot that patients are doing quite well, better than the benchmark that's shown there, what would be expected from patients in this setting from historical control, and some patients remaining on therapy even far beyond this. So this is promising, and when we're looking at responses by RECIST, the classic RECIST, where you can see that in the blue diamonds where the RECIST-based progressions are not necessarily predicting the longer term benefit as was being explained earlier. And so based on that, we also looked at other parameters to measure response other than classic RECIST, including immune RECIST to allow for at least a second confirmed progression, but also other things like ctDNA dynamics, as you heard. And so this is showing the ctDNA dynamics of evaluable patients that were able to get pre and post draws so far. Some are not at the time point yet to get the next draws. And what we saw here, as was described, some of the patients had a transient uptick in ctDNA, but then a nice decline with significant decline. And you can see here 4 of the 9 patients, or 44% of the patients, had a ctDNA response. And as has been demonstrated in many studies so far, that patients that are having ctDNA response really will predict longer term outcomes, even within 2 to 4 weeks of starting various types of therapy. And so this was shown here in this data set as well, where those patients who are having ctDNA response are having improvement in overall survival. And so you see here the progression-free survival by classic RECIST and also IPFS by immune RECIST, and particularly in the IPFS, where again, this is defined as progression at the second scan to confirm progression. You can see, particularly at long-term landmark at 1 year here, compared to historical control of what one might expect in this setting where there's no one, alive at that time without progression. We're seeing a promising amount of patients here on the order of 25 to 30%, as you heard, which is quite outstanding in microsatellite stable colorectal cancer. So now a few details on a few of the patients. One of the patients, G8, as you can see here, is a 50-year-old female with metastatic colorectal cancer, MSS. You can see that they've been through 2 lines of standard chemotherapy, FOLFOX bevacizumab, then FOLFIRI bevacizumab, and continued on maintenance 5-FU bevacizumab. And you can see there the characteristics of the biomarkers starting at baseline at the time of vaccination, showing elevated CEA, elevated liver enzymes from liver disease, elevated ctDNA, and a not outstanding or exceedingly high tumor mutation burden and a negative PD-L1 expression stain. And as has been described and is becoming quite typical of what we're seeing, the tumor markers and ctDNA, in this slide, it's the tumor marker CEA, shows an increase initially, but then a nice decline. And then ultimately, several months later, starting to see emergence of resistance. And similarly with the ctDNA now showing that exact same trend. And by ctDNA, you can see a number of different mutations some of which are here new biallelic TAP1 mutations, suggesting that this might be the mechanism of acquired resistance through reduced tumor antigen presentation that this gene is involved with. And again, you see here, even on RESIST, looking by row at different lesions and by column at different time points, you can see that at baseline to the first scan, you can see a swelling of the lesion. And then as you continue to follow, you see actually decline. And this is really very in line with what we were seeing by the tumor marker and the ctDNA. And so again, RESIST doesn't capture this at one time point. And similarly, in the same patient in the liver, having two lesions at baseline, with one of them actually having a response initially from the get-go, and one of them just being stable without growth. You can see, though, that the one that was stable before and after on PET scan on the last row, showing a clearer response by PET. So again, the limitations of looking at just the tumor sizes are emphasized here by looking at other parameters that also matter. And then in a second patient, G16 is a 63-year-old female with metastatic MSS-CRC, and you can see their treatment trajectory with first-line FOLFOX chemo and progression, then panitumumab, and then progression, and then cetuximab. And again, their baseline biomarker results showing elevated CA19-9, ctDNA, and low tumor mutation burden. PD-L1 was not done in this patient. And again, you see, the same sort of phenomenon where it takes a little bit of time by row in each of these different lesions that are being shown to shrink, but you're seeing that response over time. Another thing to point out, I think, is that the response here overall by RESIST is minus 16%, minus 19%. These by classic RESIST, of course, are considered stable because it's not, below a certain threshold that's arbitrary in some ways of less than 30%. But you can see clearly here that these are shrinking. And again, other things that I think are important are long-term survival that we're showing here on the tail of these survival curves. So with that, I will pass the baton on to Dr. Andre, and he will take it from here.
Yeah, pleasure to be with you in Paris with my French accent. Just a little overview of the situation of metastatic colorectal cancer. Metastatic colorectal cancer is a frequent disease with it's 9% of cancer in US and in Occidental country, 9% of deaths for men and women. And it's different stage, the local stage, the regional disease when it's some nodes, stage 3 colorectal cancer. And when the patient at metastasis is very difficult to cure the disease, the only way to cure the disease is to remove the metastasis by surgery. And it's not chemo responsible of some long survivor. It's the surgery. Sometimes it's possible to have surgery, and it's a way to have some patient cure with a long time. Concerning the therapies, it's now some standard of care. In first line, it's a 5-FU-based fluoropyrimidine-based chemo plus bevacizumab. It's with oxaliplatin or irinotecan, and it's with anti-GFR if the tumor is RAS wild type and left side. And if the tumor is right side, it's replaced by Bev. And now for DMMR, for MSI colorectal cancer, the standard of care is pembrolizumab, anti-PD-1, and I will show the publication and the curve. The median overall survival is between 24 and 36 months. The median PFS is between 8 and 12 months. and it's not a lot of progress since 10 years. With the progress of chemo, of all this targeted therapy, the median PFS is still the same since a long time in first line. In second line, the standard of care is to switch the chemo, irinotecan or oxaliplatin, and to have a doublet with anti-VEGF. And for patients with bad prognosis, with mutation of BRAF V62E, it's a new standard of care. It's with a phase 3, the combination of cetuximab and BRAF inhibitor encorafenib. The median survival in second line is 12 months, and the median PFS is between 4 and 6 months. We have the opportunity to have third line with some choice, but this choice is very low median PFS, 2 months, and very low median OS. We have the regorafenib, we have the trifluridine with labeling in US and around the world. It's opportunity to reintroduce anti-GFR in some patients, to oxaliplatin, to have some oxaliplatin reintroduction, and a new area is to targeting HER2, but at this time no labeling and just clinical trial. But in third line, results are poor, with poor OS and poor PFS. Just to see the PFS with the doublet, the standard of care, one of the standard of care is the PFS is increased by bevacizumab, but the study was published in a long time ago now, and the median PFS is still the same with all the maybe a little bit better if we use the 3 combination of FOLFIRINOX plus Bev, but not really different. It's around 10 months. In the introduction, it is really important to consider the fact that we have 3 kind of tumor. We have a cold tumor, we have a tumor with little immune infiltration, and we have some tumor with a huge infiltration. In metastatic colorectal cancer, it's only 5 or 6% with a hot tumor, and this tumor is in the large majority MSI and rarely microstability stable with some rare mutation like POL-E mutation. The majority are cold or with minor infiltration. The hope, the son of medical oncologist concerning the metastatic colorectal cancer was the study KEYNOTE 177. It's important. It's only a focus on MSI metastatic colorectal cancer, dMMR metastatic colorectal cancer, and Pembro improved the PFS. The p-value is highly significant. The hazard ratio is 0.6. Better than chemo. Chemo, it works a little bit less in MSI patients. And it's relatively interesting to see the beginning of the curve. It's a RECIST evaluation, and one of the reasons of the cross of the curve is because we have some pseudo progression, and if it's RECIST progression, it's an event in the curve. The result of overall survival was presented at ASCO. OS is improved by 11%. The p-value is borderline because the majority of patients receive immuno-oncology in second line, and Pembro is now the standard of care in this for this MSI patient. Result of the combi of nivolumab and ipilimumab in heavily pre-treated patient was amazing. It's the curve of PFS and the curve of OS. It's never seen in patient heavily pre-treated, and now it's clear that some patients are cured, and it's really new in the area of metastatic colorectal cancer without surgery. There is the curve of what was the past and what is the actuality right now. The curve of furopyrimidine is all patients die except some with surgery, and the PFS is 6 months. With all the targeted therapy and the combination of FOLFOX or FOLFIRI, we have improvement. It's clear that the median PFS increased, the median OS increased, but the majority of patients died, and the little minority alive at 3 years were in general with surgery of metastatic disease. The blue curve is the curve of pembrolizumab. It's the dream of the oncologist. We have to do better, but it's with pembro alone. It's maybe possible to do better with combi of anti-PD-1 and anti-CTLA-4. And we have a plateau, and we have patient cure at 3 years. We have now some patients with surgery with a complete pathological response in this situation. What about checkpoint inhibitor in microsatellite stable disease? It don't work. We have the study done by Roche with atezolizumab. It was administered in maintenance after induction chemotherapy, and no improvement by an anti-PD-L1. To conclude, it's clear now we have two different colorectal cancer. We have the MSI, it's 15% of colorectal cancer, but it's only 5% because the majority of stage 2 or 3 cure with surgery. It's patient with microsatellite instability. It's sporadic. It's the whole elderly population. It's also the Lynch syndrome. It's more prevalent in the proximal localization. It's with frequent 25% of mutation of BRAF V62, but immuno works there. Tumor mutation is very high with high immune infiltration and huge efficacy of checkpoint inhibitor. It's an example that checkpoint inhibitor can work in GI. And in the other hand, we have the majority of the colorectal cancer, 85% of metastatic colorectal cancer, with it's a proficient mismatch repair. It's anaploid tumor with loss of material genetic, and it's prevalent in the distal localization with more frequent mutation of KRAS, a low tumor burden, and no clear efficacy at this time. And this is the reason it's a huge unmet need. And with the efficacy of immuno-oncology in MSI, the dream is to have results in this population with immuno-oncology. In conclusion, colorectal cancer is the second most common cause of cancer-related deaths after the lung cancer. Outcome with diagnostic of metastatic disease is poor, only 14% at 5 years, at this time more in relation with surgery. Chemo for metastatic disease is palliative for the vast majority of patients. We have in third line poor PFS and OS. Immunotherapy give benefit only on MSI patients and in patients with mutation with a rare POL-E mutation. And early detection of disease is a key focus currently, and improved therapeutic approach in the adjuvant and first line setting are really important. Thank you for your attention.
Great, thank you, Thierry. So let's close with where we're taking the GRANITE program now. So as you've heard, colorectal cancer is a huge unmet need. And with our immunotherapy, we've clearly seen signals suggesting that we might be able to make a difference there. Now, what's helpful from a trial design perspective is that we do not need to run a third arm in a randomized trial of checkpoint inhibitor alone, because as you saw from the modal data with atezolizumab, that question as to whether checkpoint inhibitors are active as monotherapy, or actually, sorry, maintenance therapy in this disease has been answered. And the answer is unfortunately not, they're not active. And that makes it an easier trial for us to contemplate. And so immunotherapy generally is believed to work better as you move upstream. Patients have better immune systems, less complex disease, and they typically have time to mount the immune response that we obviously need to see. And some of the patients that we've treated, as you've seen, have progressed extremely quickly. And unfortunately, I think we just won't be able to help them given the rapidity with which their disease progresses. And because it takes somewhere between 8, sometimes as much as 12 or even 16 weeks for the T-cell response to really hit its peak. So for this reason, we are moving upstream in colorectal cancer in microsatellite stable disease. And the study that we've designed first, study 10, is a randomized phase 2/3 study in the first-line maintenance of metastatic microsatellite stable colorectal cancer. This is designed as an integrated phase 2/3 randomized trial. So it's a single protocol, but it has 2 discrete elements, an open label phase 2, followed by a pivotal phase 3. So the inclusion criteria that's shown on the left here, this is untreated stage 4 disease. So either newly diagnosed metastatic de novo, or a patient who previously was treated for earlier stage disease, but unfortunately their disease has recurred and progressed. These are microsatellite stable patients, BRAF wild type, which eliminates a small group of patients for whom there is a good alternative therapy, as you heard, and patients who are planned for treatment with what is in the United States the typical standard of care, FOLFOX plus bevacizumab. Patients will offer us a piece of their tumor tissue, and they're screened for their neoantigens. Roughly 60% of patients we anticipate will be accepted into the program. 40% will be rejected for insufficient predicted neoantigens. Those who are taken in are then randomized 1-to-1. Those who, they all receive exactly the same induction chemotherapy with FOLFOX plus bevacizumab. And during that induction chemo, we're making product for the patients who are allocated to the active treatment arm. When oxaliplatin is completed, and no later than 24 weeks, although most patients actually stop a little sooner because of neurotox, then the maintenance phase begins. And this, of course, is where then the treatments differ between the active arm receiving immunotherapy plus 5-FU plus Bev versus the control arm, 5-FU Bev alone. For the phase 2 portion, open label, an N of between 40 to 80, so we have some flexibility written into the protocol. And the primary endpoint for that phase is molecular response, as we've discussed. And then the phase 3 is approximately 200 patients. And the primary endpoint there, as written in the protocol, is disease progression through IPFS criteria using iRECIST for the reasons that we've discussed. Now, we took this trial to the FDA to discuss this, and they agreed with the notion of running this as an operationally combined single protocol phase 2/3 trial. But to be very clear, the phase 3 is statistically distinct from the phase 2. They are unrelated. IPFS per iRECIST will be the protocol specified primary endpoint as the protocol is launched, but the FDA will review the phase 2 data before we initiate the phase 3 component of the trial. They wish to see more data, obviously comparing RECIST and iRECIST. Importantly, as we've discussed, and for reasons you've seen, a third treatment arm of checkpoint inhibitor alone is not required in this setting. And finally, an important nuance is that it's acceptable to diagnose the MSS population basically by taking all comers and then subtracting those who are diagnosed as MSI high based on local testing. So this study will begin in early 2022. Now, we wanted to move upstream further still, and as many of you I'm sure are aware, the utility of ctDNA as a stratification tool is rising dramatically, and actually in particular in colorectal cancer. And the company Natera has done some very nice work using their tumor-informed ctDNA assay as a patient selection or stratification tool. And so the notion here is that you take patients who have stage 2-3 disease, who have definitive surgery, and of course everyone hopes that they're cured by their surgery. But sadly, somewhere between 25 to 30% unfortunately are not cured by surgery. And you can see that very early because they have persistent ctDNA in plasma. So you do an important blood draw post-op. You look for mutant DNA, and you're looking for the mutations that you know are there because you sequence the original primary tumor. So hence the term tumor-informed. If ctDNA is present, then the patient is screened for neoantigen sufficiency, as I mentioned earlier, for the study 10. And if the patient does have sufficient neoantigens, they're then randomized to receive either immunotherapy as maintenance after adjuvant chemo or simple observation after adjuvant chemo. The endpoints for this study will be ctDNA and disease-free survival, with overall survival obviously a remote endpoint. And ctDNA is very powerful to enable this kind of study because the data from Natera suggests that patients who are ctDNA positive post-op will experience disease recurrence at around 12 months. So pretty much everybody has recurred by around 14, 15 months, which means this trial is efficient. Everybody in the trial gives an endpoint. It's also an important trial because these patients need help. They are going to recur, and standard of care, unfortunately, is unlikely to be sufficient. Hence the rationale for adding in immunotherapy in this patient group. And obviously this is as early as we can go at this point, but obviously a very interesting design. Okay, with that, our presentation is complete. We have 15 minutes left if we want to finish at the hour. So let's hand this over to Q&A. Back to Tara, please.
Thank you, Andrew. At this time, we'll be conducting a question and answer session. If you would like to submit a question, you may do so by using the Q&A text box at the bottom of the webcast player, or by emailing your questions to questions@lifesciadvisors.com. To our analysts, we invite you to join via Zoom. Please hold while we pull for questions. Our first question comes from Elizabeth Webster at Goldman Sachs. Elizabeth, please go ahead and unmute your line.
You're muted, Elizabeth. I'm afraid we're not hearing anything. If you can't get the microphone to work, Elizabeth, perhaps you could submit the question in written form and we can answer it through that medium. Yep, let's move to the next question, please, Tara.
Okay, great. The next question comes from Thomas Schrader at BTIG. Thomas, please go ahead and unmute your line.
Do you hear me okay?
Can hear you fine, Tom. Good afternoon.
So thanks for all the detail, and I have to congratulate the company on doing a huge amount of heavy lifting in a difficult area. So, you know, it's good stuff. A question for Dr. Tadanaji. I think it's pretty appealing that ctDNA changes predict some sort of bigger benefit. How quickly do you think you would trust ctDNA data to say to a patient, you should really be patient here, you're likely to benefit?
I think it's a great question. And, you know, I think you see the trajectory that in this setting, there is an uptick. And so getting too excited early, I think would be premature. I think that, you know, certainly by a couple of months later, if you would be seeing response by ctDNA objectively. And as I showed you, that typically predicts longer term benefit. And when you compare to patients who aren't having such a response.
Okay, thank you. And then if we can return to syllogisms now that I've looked them up. Is ctDNA really different than a tumor response, or is RECIST just too high a bar? Does a patient, are you confident that a patient will benefit if they have a 10% reduction in tumor volume? And is ctDNA just more sensitive, or is it really different? And I think you had one patient where the tumor got bigger and ctDNA went down. Is that just a spot in time, or is that an interesting patient?
Yeah, I think that you're getting it exactly right, where I showed the patient that actually had a concordant increase in size of the mass and increase in ctDNA, and then both eventually drop. And so, you know, so the first part of your question, in terms of, do I believe the ctDNA more than the changes in the size on the scans? You know, this concept of pseudoprogression with immunotherapy is a known phenomenon now. Like there are a number of publications, melanoma is you know the primary site of that, where patients are looking like they're progressing on scans classically, but ctDNA doesn't lie. And there are publications that show that patients who are showing decrease or discordances with what you're seeing on scan and what you're seeing by ctDNA, the ctDNA predicts the reality. And so as opposed to those patients who are truly progressing, you'll see the ctDNA continually rise. And so I think ctDNA has been demonstrating to be very important and instrumental in helping to differentiate that. And I think that, you know, this is the tip of the iceberg here now with vaccination, because this is yet another variable that I think takes even a little bit more time, as you've been hearing, to generate that response. So it may be even more accentuated, I think, this initial uptick before you see response. And patience, I think, is going to be required.
Great, thank you.
Thanks, Tom.
Thank you for the questions, Tom. The next question comes from Sean Lee at H.C. Wainwright. Sean, please go ahead and unmute your line.
Good afternoon, guys, and thanks for taking my question. My first question is on the patient's relative T-cell response compared to their ctDNA level and especially survival. Have you seen any positive correlation between these?
There's not a strong correlation. I think we need more data to answer that question for sure. It's interesting that some of the early patients, the ones numbered G1, 2, 3, if you go back and look at that T-cell response slide, they had some of the best T-cell responses. It's interesting, actually, they were dosed with the lowest dose of self-amplifying RNA. And parenthetically, it looks as though that actually is the better dose. Self-amplifying RNA is an unusual beast because it does make copies of itself, and therefore, unlike pretty much every other drug we give where you get what you're given, with self-amplifying RNA, you get something more than you're given, and we've been figuring that out. Some of those patients did remarkably well, and one of those patients, G2, is actually one of Dr. Catanacci's patients who had a very nice T-cell response. Dan, do you want to speak to that patient? Patient 9, I think.
Yeah. So he had an excellent response and was doing very well for some time before eventually developing brain metastases. But before that, he was doing very well for longer than like a year and a half before progressing.
I was thinking of your G2, who had the even better response as well, the gastric cancer patient with the who had no evidence of disease at baseline.
Oh, okay. Not knowing them by the numbers. Yeah. So that patient's an interesting one that had stage 4 metastatic G junction cancer that classically has a very bad outcome, less than 5% 5-year survival rate, and was doing very well. By the time that the patient's vaccine was ready, actually had a nice response to the induction chemotherapy that we were giving in the setting as a bridge to getting to the vaccination. And actually, we went to surgery because his baseline disease was oligometastatic, so to speak. So the primary tumor was removed, and the residual disease that was likely left behind in some metastatic lymph nodes was the concern, and that's why we don't typically do that unless they have a dramatic response. But his expectation for recurrence was more than 80%. And so then the patient was vaccinated, had extremely high T-cell response, and even to date now I think it's been 2 years or more since surgery without evidence of disease, and his ctDNA actually post-operatively was a little bit elevated and now remains non-detectable. So this is an example, I think, that we're alluding to moving this vaccination strategy to earlier settings and as an adjuvant to suppress a likely recurrence. And so far, this patient really fits that situation, I think.
Yeah, had a very nice T-cell response. So I think very soft data, Sean. We just need more data at a fixed dose, which obviously is coming next.
Thank you for that. That was helpful. My last question is on during the course of treatment, have you seen any specific mutations or types of epitopes that turn up that more often the responders compared to the non-responders? And or is there any other clinical biomarkers that you've seen that has a positive prognostic value?
So the obvious negative prognostic biomarker is a very high ctDNA at baseline. If you have a ctDNA measured in 500 or greater, and this is in human genome equivalents per mil, which is the now standard units used for measuring ctDNA, if you're over 500, you're going to progress extremely quickly and probably before our therapy has a chance to help you. And again, this is one of the benefits of moving upstream, is that we hopefully will not have those patients being very numerous in our sample set, because we probably can't help those poor subjects. So that's the most obvious prognostic factor we've observed. There's no other common mutation shared between patients. And remember, of course, that with GRANITE, pretty much every mutation is personal, right? These are your passenger mutations. There's very little sharing between subjects. So there's no common pattern that we've observed in terms of that mutational architecture. One thing that did pop up, and Dan mentioned this in his talk just now, was this very interesting observation of a biallelic TAP1 mutation in that patient G8, who was doing very well, had a complete molecular response, was heading towards a year. And at around a year, we started to see mutant DNA reappearing in her blood, unfortunately. So we kind of knew that she was going to radiologically recur, which she did at around 15 months with a liver metastasis appearing on radiology. But what was noticeable is that when we screen actually for some sort of candidate resistance mutations, and she developed biallelic TAP1 mutations, meaning she had one mutation in one TAP1 allele and a different mutation in the other TAP1 allele, which obviously basically doesn't happen by chance and is very strong evidence that indeed it was evasion of the class 1 directed immune response that led to acquired resistance for that patient. So that was very interesting. And we've got some other data that we'll probably present at a scientific meeting where we've seen similar phenomena in a couple of other subjects with delayed acquired resistance, which is obviously good news, bad news. The bad news, of course, is its resistance. The good news is that it does at least suggest when we see these recurrent alterations in class 1 antigen processing and presentation that our therapy is doing what it's meant to do.
Thank you for the additional color, and thanks again for taking my questions.
Very good. Thank you, Sean. Okay, I think we're going to move to written questions now. So I'll read out the questions. The first couple of questions come from Mark Frame at Cowen. His first question: do you see differences in the ctDNA response for sequences included in the vaccine cassette versus sequences that were not included? That's his first question. The simple answer is generally no. All of the mutations travel together. And if you go back at your leisure and look at the slides where we showed you the ctDNA data, for example, for patient G8, on the left on that slide, you can see a huge mass of lines. Those are all of her tumor mutations being tracked over time. And then on the right were her 20 vaccine included mutations, and they basically all travel together. So we've not seen much evidence yet of subclonality happening, meaning that you see some clones remaining suppressed with certain mutations remaining low, but others breaking through on a resistant clone. We've generally seen all of the mutations traveling together. Then there's the next question: how do the ctDNA sequences that are declining compare to the epitopes against which you can detect meaningful T-cell responses occurring? It's a little challenging to answer that question because we don't get enough blood typically from a regular blood draw to actually measure single antigen-specific CD8 T-cell responses. There just aren't enough T-cells in a standard 10 ml blood draw. So we have to measure using mini pools of peptides covering multiple candidate neoantigens. So can't really answer that question currently. And then Mark's final question: how does the evidence for ctDNA responses being meaningful differ between immune therapies like this versus traditional therapies? So that's an interesting question. I'll maybe take a stab at it and then hand it back to Dan and Thierry. Obviously, with immune therapies, we're heavily incented to start looking for better biomarkers because radiology is failing us. We're seeing lots of evidence now that in particular stable disease doesn't seem to mean very much. It can be bad, it can be good. And ctDNA helps us dissociate those two populations. Immunocore, who I mentioned earlier, have shown that in their patients who actually were labeled as progressive disease by RESIST, when they broke them into ctDNA responders versus non-responders, even people who were labeled PD were actually did very well, had good long-term survival outcomes. So clearly, ctDNA for immunotherapy is really helping provide illumination of this very large and rather useless SD, stable disease population. There's less work been done, I think, with traditional therapies because RECIST works okay for traditional cytotoxic and targeted therapies. So the incentive to do the work is not there. I think it's there now with immunotherapy. But let me hand over Dan. Thierry, any comments on this question?
I agree with your comments. It's a clear relationship between the efficacy of chemo and cDNA, and metastatic disease is not used because complex at this time, because no labeling with a lot of possibility, but in adjuvant setting, it's no progress since a long time, and really all the study, not all, but the majority of study use cDNA to try to select and to see the effect of therapy, and it's really a new step, and for especially for adjuvant, it's a key point. For metastatic and immuno-oncology is probably also a key point, because pseudoprogression is really a problem, and it's a way to better understand the pseudoprogression at the beginning, and it's a very important tool.
Thank you. Okay, let's move on. So Elizabeth Webster, we now have your question. I'm sorry we couldn't hear you live, but thank you for writing it in. Elizabeth's question from Goldman Sachs. For GRANITE, a molecular response is defined as a 50% or greater reduction in ctDNA from baseline. Could you provide some color on that threshold and how it was set? The simple answer is that's now widely used in the literature. So that's why we chose 50% as the threshold. Some people have used 30%, but I think most folks now are settling on a 50% reduction as being standard. Dan, Thierry, would you agree with that?
Yeah, I would agree with that, and I think it's somewhat arbitrary. I certainly see that that's the threshold that's been adopted, and generally predicts the longer term benefit.
Agree.
Yep. Thank you. Okay, let's move on. Next question is from Yuan Ji at B. Riley. Yuan asks, just like COVID vaccine can induce T cells that have activity towards a set of T cell epitopes, in your clinical trial with SLATE vaccine, did you measure T cells from patients to see, one, if T cells are induced, and two, how strong the response is towards the set of T cell epitopes? So yes, we absolutely did that, Yuan, and we were disappointed with the T cell responses with version 1. Based on the GRANITE data, and we started GRANITE a little bit before SLATE, we were expecting to see strong CD8 responses measurable in hundreds of T cells per 10 to the 6 PBMCs in the standard overnight ELISpot assay. And we saw that in a couple of patients, but we did not see that in the majority. And we were puzzled. And we went back and interestingly, because we put P53 into this version 1 cassette, and P53 was presented by some common HLA alleles, we could actually measure the P53 specific response as a control. It was useless because the patients didn't have P53 mutations in their tumors, but it was actually quite a useful vaccine immunogenicity control. And what we learned was that P53 was driving a very strong CD8 T cell response. So we appear to be defining what's now thought of as a hierarchy of immunodominance within human shared neoantigens, which obviously is a new area and no one knew this before, but it looks like P53 is clearly immunodominant over KRAS, perhaps because there's more P53 HLA peptide complex on the surface of the tumor cell, and that's what drives its apparent dominance. So for version 2, we kicked out P53, we repeated KRAS, and you observed, I showed you the mouse data, transgenic mouse data, suggesting that we should see superior responses in humans, which we anticipate will lead to better clinical effect. So we're hoping to see a further amplification of the effects in non-small cell, and perhaps we'll start to see effects of benefit in colorectal. Okay, let's keep moving. Next question is from Wayne Kerr at Dover Solutions. When can we expect to hear any further readouts regarding this program? So we'll be launching the phase 2 randomized studies, as I mentioned, in the first half of 2022. The O10 study, the maintenance study, is open label, and so we should have some data in 2023. So I think that would be the relevant timeframe. For SLATE, we will expect to have data from V2 in mid-22, so that's a much more near-term catalyst. Next question is from Sultan Beardsley at MSMM. Does the data potentially support accelerated approval in third-line MSS-CRC patients, particularly the ones with liver metastases? I think the simple answer today is no, because the FDA has not accepted ctDNA response as a surrogate for accelerated approval. Obviously, everybody's watching this space closely, but to this point, the answer is no. And because we haven't seen RECIST radiologic responses in colorectal, then obviously we would not expect to use RECIST response as the basis for accelerated approval either. That's why I think that the right path is to do a randomized study using alternative endpoints. Next question comes from Fadi Karam. Do you expect any support from the government, NCI, or other foundations as you continue to lead the science on CD8 cells for treating tumors? We're always open to that. And James Gully, who leads the NCI tumor vaccine division, is a member of our scientific advisory board. So obviously we speak and work closely with James. And if there is an opportunity for us to work together, we obviously would enjoy that, I'm sure. Okay, next question from an unattributed question. Are you looking for ctDNA increases as a predictor of loss of response that is not included as a predicted neoantigen that could inform a new vaccine? Okay, I think I get the question. Yeah, we certainly are monitoring those data. If we did start to see evidence that a particular mutation, particularly if it was subclonal, was breaking through when other mutations were remaining suppressed, and we did not think that that was a good neoantigen, that would be evidence perhaps that we need to think again. So I think a simple answer would be yes, we are collecting those data, but again, because every patient is different, it is very hard to draw broad general conclusions because all of the mutations essentially with GRANITE are distinct. Next question, for patients who do not progress rapidly, what is known about the mechanism of response? Okay, are you looking for ctDNA increases as a predictor of loss of response? Okay, so I think that's more of the same question, really. I think we've covered that. Okay, last question, I think. What from Nick Abbott at Wells? Why do you think the GEA patients, that's the gastroesophageal adenocarcinoma patients, did so poorly? Too much early progression? Question mark. Dan, you're probably the right person to answer that question.
I think has been alluded to, a lot of these patients are sick, and so by the time the vaccine's ready, whether it be whatever tumor type it is, when we're looking at later stage disease of these tumors, it's too late, and it's too late to mount the response. So in patients that we can get it to them early, I think that's where we're going to have a bigger impact.
Very good. Okay, those are the questions. Any closing comments? Thierry, Dan, anything else you'd like to add?
Just a comment about the fact that to have an induction therapy and to have during the induction therapy the time to do and to prepare the vaccine is very important. And for that, colorectal cancer is really a good choice, and also because it's very ethics, because all patients receive the standard of care during the first part of the therapy, and it will be very easy to include patients in this trial.
Very good, thank you, Thierry. Dan?
Yeah, I 100% agree, and there's not much more to say other than I think that as we use that as a beachhead, and if we're starting to see, what we're wanting to see, then they can be expanded to other tumor types like gastroesophageal cancer, but in earlier settings.
So the point is the adjuvant project, because we have really to improve the things, and cDNA is crucial. And we have with cDNA patient with a very high risk of relapse, and it will be not necessary to have a lot of patients to see something like we had in the past with a huge phase 3 in adjuvant setting. It's really a way to select patients with bad prognosis, and it's really not necessary to have huge trial, but to select patients with high risk, and with that probably it will be rapid to have the answer at the question with not a lot of patients.
Bad prognosis, but low tumor burden, which is, I think, the time to come in with something like this to suppress in any tumor type. I think that's going to be important.
Very good. Excellent. Well, thank you very much. So first of all, Thierry, thank you for making us feel like we're in Paris. We really appreciate it. I wish we could have been with you in person.
It's no meeting is the reason.
That's right. Thank you, Dan, for traveling. And thank you all for your interest, for your questions. We appreciate it. And obviously, you can reach us through investor relations at Gritstone Bio if there are any further questions. And with that, I think we will close the meeting. So thank you, everybody.